You have to study. Kasi the moment that you would be thinking na there's a lot of pages to cover, yan talaga ang magiging ano nyo. That would be a major step back, okay, when you study. You just study and study and study. Okay? Never mind if you will finish it as long as you were able to read, okay, something about it. Okay? Ganun lang. You just study and study. We will never stop studying when you are a doctor. Okay, take note of that. Even consultants who are 85 years old, like Dr. Villano of Davao Doctors Hospital, he still would study journals. Okay, so there's constant development in your brain when you are doctor. So study and study and study. Okay, yan lang ang ating magagawa ngayon. Okay, so let's go. Let's go with cardiac pathology. So 15 lang pala. So I'll just give you a background dun sa slides natin. And then the rest would be given by the respective lab instructors. Okay. Share screen. So we will start with thrombosis. Wala din yung thrombosis. Kailangan natin padagdag. Hypotizing vasculitis. Wala din. Ito. Cutaneous vasculitis. So, alam ko nakita niyo na yung slide ko. Okay na slide ko, Marian? Can you view it?
Yes po, Doc.
Okay.
Na-view na po.
So, this is labeled as cutaneous vasculitis. So, this is skin tissue. And cutaneous vasculitis can be associated with certain conditions that would be it can be part of an infection. Okay, so this would fall under type 2 if there would be the presence of ANCA, anti-nuclear cytoplasmic antibodies. Okay, and what we would see here would be the presence of a lot of neutrophils in the subcutaneous tissue as well as in the papillary dermis. So ito na siya ang fibroadipose tissue, and then this would be the skeletal muscle. Okay. So notice a lot of inflammatory cells in the area, so neutrophils. So this would be the part of the slide that you need to look for. Okay, so this would be the blood vessel. Okay, that would be surrounded by a lot of neutrophilic infiltrates. So this is another blood vessel, but this time you would see a fibrinoid necrosis at the area of the blood vessel. So you see a lot of neutrophilic infiltrates. Okay. So let us try to look for another blood vessel. So that would be vasculitis. Okay. Here, this one is another blood vessel. You would see it to be lined by endothelial cells. And then you have the amorphous pink material, that would be the fibrinoid necrosis, and then you have neutrophils. Okay, so next we have temporal arthritis. So temporal arteritis would fall under the large vessel vasculitis, and this is seen in older individuals, that is 50 years old and above. Temporal arteritis can also be called as giant cell arteritis. And temporal artery biopsy would be done, and it shows a fish mouth, okay, or a slit-like appearance of the lumen. Okay? Unlike in normal blood vessel lumen, it would be round or oval. This time it is slit-like. Okay, so there would be the fragmentation of the elastin fibers, okay, found separating the intima, tunica intima, as well as that of the tunica media. And there's a lot of inflammatory cells present, okay, and the inflammatory cells present here would be epithelioid histiocytes. So there's an inflammation present in the slide, and this would be more of granulomatous inflammation. Okay, you can see the cells that have round to ovoid vesicular nuclei. Okay, so this is temporal arteritis. So dito pa lang, makita nyo na, this is cross-section of the temporal artery with the slit-like vascular lumen, high power magnification. You can see the presence of inflammatory cells, and they are mainly epithelioid histiocytes. Okay. Next, we have cystic medial necrosis of the aorta. So in cystic medial necrosis, this would be a prelude to aortic dissection, okay? Or this would be one of the conditions, aside from hypertension, that would be the etiology for aortic dissection. So and you can see that, okay, in this particular area, you have the muscle fiber, but there are portions, okay, that would show separation, okay, of the smooth muscle fibers. They should be together like this, okay. However, in some areas, you would see separation by this myxoid, okay, amorphous material. Okay, so they can be hyaluronic, hyaluronan, okay, or connective tissues that would be deposited, okay, interspersed between those smooth muscle fibers. Okay, so connective tissue diseases can be the reasons for the deposition. Okay, and this can be one of the causes again of aortic dissection. So next slide, we have aortic dissection. Yeah. Okay. So aortic dissection uh, in this particular image would show a double, what they call as a double barrel lumen. Okay. So okay, and the other would be the true lumen. Okay. So this would be the true lumen. Okay. And this would be the false lumen. Okay. So what happens in aortic dissection is because of the weakening of the smooth muscle of the tunica media, there would be the formation of a tear, laminal tear, okay, at the central portion of the tunica media. Okay, go to this part, okay. So there would be a laminar tear, okay, at the middle of the tunica media. Okay. So this tear will cause a decrease in the blood pressure of the patient. There would be the presence of a lot of blood going into this lumen. okay, the false lumen, and this can cause hypovolemic shock in our patients. Okay, so this is an emergency, and I have seen, okay, as a pathology resident, I have seen several cases of aortic dissection. If you remember, Mikey Arroyo, okay, Mikey Arroyo, the husband of former President Gloria Macapagal Arroyo, he suffered from aortic dissection. Okay, so the causes for aortic dissection would either be okay, necrosis of the aorta. Okay, so next we have next we have the different slides pertaining to myocardial infarction. So we start with uh, 201. This is MI 48 hours. Myocardial infarction 48 hours. So actually we have 5 slides, okay, for myocardial infarction, showing to us the different um, histologic appearances from 48 hours or 2 days, then 4 days, then 8 to 10 days, and 6 months. So we are going to start with an acute MI 48 hours or myocardial infarct 48 hours or myocardial infarction 48 hours. So what happens? Try to zoom. So what happens in this case is that there would be the presence of eosinophilia. Okay, kita. Nanap ko lang. Okay. So there are areas wherein we would still appreciate the presence of uh, the nuclear features of the myocytes. Yan. Okay. But also there are areas like this portion that are devoid of the nuclei. And take note of the change in the color. Okay, so one of the characteristic histologic appearances of dead cells would be hypereosinophilia. Okay, so you can see the difference but between this particular area and this particular area. There's a change in the color. Dito it's darker, this one would be lighter. Okay, darker and lighter. And then another feature would be the absence of the nuclei. This particular area, you would still see or appreciate the presence of the nuclei, which would be centrally placed. Okay, and then another feature is that there would be neutrophilic infiltrates. Okay, this particular area, not so much, diba? Not so much, but in this particular area, you can see the presence of inflammatory cells. Okay. So with regards to the type of necrosis, so ano bang type of necrosis present in this particular slide? Kevin, what do you remember? Would it be liquefactive, coagulative, caseous, fibrinoid necrosis? Okay. What is it? Charles, what is the type of necrosis that we would see?
Coagulative po, Doc.
Okay, coagulative. Okay, so those features would be for coagulative because if we are going to say this is liquefactive, even though we have the presence of neutrophilic infiltrates, we should not be able to identify the architectural pattern of the myocytes. Okay, so when we have liquefactive necrosis, they would form a fibrocellular mass. It means that they become necrotic debris. Okay, so again, you look at areas wherein there would be absence of the nuclei. In this particular area, you can see the presence of the nuclei and take note of the color. This one is darker, di ba? This one is lighter. you see the presence of nuclei in this particular area absent. Okay, we have more of the neutrophils here, di ba, less? So those are criteria that we have to look at. So this is a very good slide because you would be able to identify which of the areas are affected by the infarction. Okay, so always try out in this particular area. You look at the difference. Okay, this one is the normal. What's the difference? Change in the color. Darker, lighter. Okay, scanning view. You can see a lot of inflammatory cells in this particular area. Less, di ba? And then lastly would be the presence of nuclear features. Okay, dito, meron tayong nuclear feature. Absence of nuclear features. Okay, what about this one? Should this be normal or not? I'm not sure because it has a nuclear feature. But one of the features of coagulative necrosis would be cardialysis, di ba? When you say cardialysis, it may be seen as fading of the chromatin, which would mean that we still would appreciate the presence of the nuclei, or there should be fading of the chromatin. But in this case, we still appreciate the presence of the nuclei. So we're not sure if this is now in the early phase of necrosis, but you can see that there's color change already. Okay, so this one is myocardial infarction. So what are the features that we would see during the first 48 hours? Okay, hypereosinophilia, the presence of coagulative necrosis, the presence of neutrophilic infiltrates, and then another one would be waviness of the fiber. Yan, makikita nyo may waviness of the fiber. Yan. Okay? Ano pa tayo na alam ng areas. So this particular area, this is already part of infarction. You can see the presence of a lot of neutrophilic infiltrates. Okay? Yan. Sige, next we go to myocardial infarction 4 days. So what happens with 4 days? As what we have learned in inflammation, first 3 days, what type of inflammatory cell would be present or appreciated? Germs. What type of inflammatory cell would be predominantly present during the first 3 days of inflammation? Ano siya? What would be the type of inflammatory cell during the first 3 days of inflammation? Arvin?
Sa first 3 days po, Doc, neutrophils.
Okay, neutrophil. Okay, so understandably, because this is 4 days, there would be a shift. So the predominant cell that would be seen would now be lymphocytes or histiocytes. And take note, in this particular view, what would be evident? What would be evident? You would still be able to see some outlines, but now there is a form of disintegration. Okay, that is very important of the cardiac myocytes because of the lysis, it has been eaten up. Portions of the neutrophils as well as the histiocytes. Yeah, so very important. Okay. So all the areas here would show the presence of the ghost outlines. Okay, but there's disintegration already of the myocytes. Yeah. Very important. Yeah. So it means that this is more than 3 days old. Okay. Next we have myocardial infarction 8 to 10 days. Okay. So what have we learned about inflammation in 8 to 10 days after? So what we would see would be the presence of what do we see? The presence of granulation tissue. Okay. So during the starting with 3 days, there would be formation of granulation tissue. But in the previous slide, it's what we would see would be the disintegration. But during the 8 to 10 days, there would be maximal granulation tissue formation. What would be the features that we would associate with granulation tissue formation would be the presence of blood vessels, the presence of fibrosis, and the presence of mononuclear cell infiltrates. Yeah. So let us try to look at the area. So this would show the presence of proliferating blood vessels. Okay. Here you would see the presence of proliferating blood vessels. There, the presence of proliferating vessels, the presence of fibrosis and mononuclear cell infiltrates. So in the practical exam, if you would see the presence of cardiac myocytes, and then we're going to point to you this feature. What are they? Presence of blood vessel proliferation, the presence of fibrosis, kasi it's different from the myocytes, and then you would see inflammatory cells, mononuclear cell infiltrates. Let's try to look for other areas. Okay. And so the moment that you would see the presence of blood vessels, this one would be fibrin. So this is not a good area. This one is good area. You would see the presence of blood vessel proliferation, histiocytes, fibrosis, and then you have mononuclear cells. In this particular area, not so good. I think those are the areas that you need to identify. Okay. Of course, this one would be part of granulation tissue. Okay, wherein you have fibrin deposition, okay, as well as red blood cells in the area. Next, we have 1 month after. Okay. So in 1 month after, you have here the cardiac myocytes. Again, you have to go back to this particular slide because this may confuse you with amyloidosis of the heart. Okay, you go back to this particular slide next time. So what are the features when we have MI 1 month after? Very prominent would be the presence of fibrosis. So you have here the presence of the myocytes, okay? But also you have here areas of fibrosis. You have granulation tissue formation still. There, you still have the presence of the blood vessel formation. You have the presence of mononuclear cell infiltrates, as well as the fibrosis. Okay. Here, you have more granulation tissue, but the granulation tissue here would present with more fibrosis. Here, you have another set of granulation tissue in this area. Okay, so 1 month after, you would see more fibrosis, but still would show the presence or appreciate the presence of granulation tissue. What about 6 months after? Okay. So 6 months after, what we would see would be the presence of fibrosis. Okay, you still have occasional blood vessel formation, but absence of inflammatory cells. Okay, so you have areas of fibrosis that may not present with granulation tissue formation. Okay, kasi 6 months na siya. It means that the tissue repair has been complete. Okay, you might see some blood vessels, but it is not presenting, not associated with mononuclear cell infiltrates. It means that it is simply a blood vessel present in the fibrous area or fibrotic area, but this is not considered as a granulation tissue. So for you to be able to say that this is granulation tissue formation, there should be the presence of mononuclear cell infiltrates surrounding the blood vessels, accompanied by fibrosis. Okay? So that would be for the myocardial infarction. Next, we have, I think this would be the pericarditis. So for pericarditis, bacterial muna tayo. Bacterial endocarditis. Okay, so this is in the book, this would be falling under infective endocarditis or IE. Diba? Bacterial endocarditis can be it can be associated with Staphylococcus aureus or Streptococcus, or it can be associated with less virulent organisms. Okay, so for the infective endocarditis, that would be in this particular view, it would show this would be a leaflet, and at the surface of the leaflets, you can see this discoloration, which are the bacterial colonies. This would be calcification. The calcifications would be accompanied by this blue blue structures. These are bacterial colonies. Ito siya, bacterial colonies. Here, we have bacterial colonies. Okay. So in infective endocarditis, if it is caused by Staphylococcus, it may require surgical intervention, okay, as well as antibiotic treatment. But for the less virulent organisms, it may be less damaging to the leaflets and may only require antibiotic treatment. Next, we have constrictive pericarditis. So in this particular slide, you would see myocytes on the left side, and then this would be part of the pericardium. The pericardium would be composed of fibroadipose to fibrocollagenous tissue. Okay? And then you would see the presence of the blood vessels. So, but in this particular slide, you would notice that the pericardium is very thick, encompassing from this particular area up to this portion. So constrictive pericarditis can cause restrictive cardiomyopathy, and it can be caused by the presence of inflammatory lesions. In this case, the inflammation here would be tuberculosis. Okay, so you can see the presence of granulomas. Here you have granulomas. You have here granulomas, and then this cells present here are actually epithelioid. These are Langhans type giant cells. This one. Okay, so those are Langhans type giant cells, and this would mean that there would be the presence of chronic granulomatous inflammation. So that would be the etiology for constrictive pericarditis. Okay. So again, the composition of the pericardium would be fibrocollagenous to fibroadipose tissue. In this particular case, there would be thickening of the pericardium. Okay, there's the presence of fibrosis as well as inflammation brought about by the presence of chronic granulomatous inflammation, characterized by granulomas formed by epithelioid histiocytes, as well as the presence of Langhans type giant cell. And Langhans type giant cell. You can go back to the slide. And then you have, not present here, but acute fibrinous pericarditis. I have to inform the IT that it's not present, but it's in the manual. And last slide, last set of slides, we have amyloidosis. Okay, so I think we have covered this one in immunity last semester. So let us try to look at this particular slide. So amyloidosis is caused by deposition of double A, amyloid associated, okay, protein. And it can be localized, okay, like if it can be the only organ that would be affected, or it can be associated with a systemic type of amyloidosis wherein other organs would be affected. So what would be the main feature for this particular case is that we have the presence of the cardiac myocytes, okay, that would be separated by this amorphous substance. Okay, so the myocytes should be like this. Okay, so they should be seen in syncytial formations so that they can move as one. But in this case, you have areas of seemingly like they are fibrotic. That's why you have to differentiate this one from myocardial infarction. Okay, 8 to 10 days. So we have here the separation of cardiac myocytes, and there's separation of cardiac myocytes. So one way to identify that this is not simply fibrosis is through the use of Congo red stain, which would be able to highlight the amyloid deposits uh, as having an apple green by refringence when we use a polarizing microscope. Okay, so this is amyloidosis. So you can see again the separation of the cardiac myocytes. Yeah. Okay, cardiac myocytes. We try to distinguish this one from MI 6 months and MI 1 month. Next, we have hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy, or HCM, is identified with the genetic mutation, okay, of the sarcomeric proteins. So this is a genetic mutation. What we have here would be the irregular formation of the cardiac myocytes. So they can be seen here as having oblique formation. They can be horizontally formed. There is a haphazard arrangement, so that would be very characteristic for uh, hypertrophic cardiomyopathy. Okay, here you arrangement of the cardiac myocytes. Okay, and there is a myocardial disarray. Okay, that would be very important when you are going to look at the slide for hypertrophic cardiomyopathy. Okay, so there would be irregular or haphazard formation of the cardiac myocytes. So another feature is that there should be hypertrophy. So the myocytes should be very thick. And the hypertrophic cardiomyopathy here, again, would be associated with a genetic mutation due to sarcomeric protein. Okay? Genetic mutation of the sarcomeric protein. Okay? Next, we have cardiac myxoma. So cardiac myxoma is a tumor. So we have encountered this one sa mutation. This is benign. And you need to differentiate this one from congestive of the lung. Okay, so we'll try to check on that one. So in myxoma, you have the presence of myxoma cells. They are stellate. Okay, they are stellate. They are stellate. They are oval. Okay, they're seen in aggregates. They are surrounded by a fibromyxoid stroma. Okay, and then sometimes you would see the presence of hemosiderophagus. Okay, so again, stellate cells, fibromyxoid stroma, hemosiderophagus, would be cardiac myxoma. The cardiac myxoma is benign, but if it's large enough, it can cause cardiac tamponade. So last slide would be chronic passive congestion of the lung. So chronic passive congestion of the lung is, you cannot see anything in this particular view. We go to the high power magnification. So you would see the presence of alveolar structures that would show the presence of hemosiderin-laden macrophages. Okay, this would be seen in left-sided heart failure. Okay. And then you have the presence of heart failure cells. Okay, heart failure cells. Just make sure that you would be able to differentiate this one, okay, from myxoma, because they also would present with cardiac, with this hemosiderophagus, but doesn't show the fibromyxoid stroma. Okay. So that's it. We have the slides for cardiac pathology. I think it would be given to you later, okay, but at least you know already what are the different slides that you have to look into for the virtual microscopy. Okay, so I think our last, I'm not sure if we still have the makeup, di ba? The makeup class next week. Pero just in case that we have it, we're going to move the oral reporting. But if we do that particular makeup class next week, but if the oral, if there's no oral reporting, we will continue with the makeup class, with the oral reporting next week. Okay, so I'll give the questions as well as the grouping after the practical exam later. Okay, so I'll see you 6 p.m. okay, for the exam. So any questions, Justin?
None po, Doc.
None? Okay, sige. Okay, sige. Kevin, any question? Wala? Sige.
Bye-bye.
Okay. Thank you. Bye-bye.
Sige po, Doc.
Bye-bye.
Thank you, Doc.
Okay.
Thank you, Doc.